Patient X is a 64-year-old African-American female with a drug allergy to penicillin. She's a CPR full code. She came into the emergency room on 4/13 via ambulance, presenting with sharp 10 out of 10 lower back pain that radiated down to her right posterior hip and leg. She noted acutely worsening pain on 4/11, the Friday before, becoming bedbound due to pain. She also had an episode of urinary incontinence as the pain prevented her from being able to get up and use the restroom. A CT scan was done on the lumbar spine without contrast, revealing annular bulging with significant facet degeneration and spinal stenosis at L3 to L4, L4 to L5, and L5 to S1. It also revealed L4 to L5 spondylolisthesis. She was admitted to inpatient on 4/14 with a diagnosis of right lumbar radiculopathy and intractable back pain, where she's currently being treated for symptom management. She underwent an MRI of her lumbar spine without contrast, which showed spondylosis in her lower back and significant narrowing at L5 to S1, especially on the right side. She also had a bilateral hip and pelvis x-ray, which was negative. She requires a one-person assist with ambulation and bathing, but independently feeds herself and performs oral care. As for her medical history, patient X reported bouts of low back pain back in December of 2024 that improved with medication. She also has a history of essential hypertension, hyperlipidemia, and type 2 diabetes mellitus without complications. There's no past surgical history on file. All of her vital signs have been within normal range except her blood pressure. Her last reading was 97/51, so a little hypotensive. As a result, we ended up holding off on her amlodipine and lisinopril, and we're actively encouraging hydration. Otherwise, she took all of her other medications as prescribed. Additionally, her last blood glucose was 194, so she will need some insulin before her next meal. Her bun level was 22, which is a little high, likely due to her hypertension or type 2 diabetes. Her hematocrit, hemoglobin, and red blood cell count were all low, possibly due to nutritional deficiencies. I definitely recommend that you check on her after her meals to see what she's eating versus not, so that maybe we can come to a conclusion on whether nutrition is playing a role or not. As for her pain, she's been reporting an ongoing 5 out of 10 lower back pain that radiates down to her right hip and lower leg. She describes it as sharp, achy, and a general discomfort. It feels better with pain medication and worse with movement. It's been making her gait unstable and limiting her range of motion as well. Her prescribed Voltaren NSAID gel was applied but provided no relief, so I recommend possibly requesting an order for an oral NSAID but keeping the gel as PRN, as well as possibly incorporating some ice or heat therapy. I also attempted to contact the doctor for a low-dose opioid analgesic order at the request of the patient, but he was unwilling to prescribe it. I would definitely recommend that you keep trying and pushing for this request. Additionally, PT was consulted in an effort to incorporate therapeutic exercise, but the patient was in too much pain for it to be effective. She's alert and oriented ×4. Her speech is clear. She has weak motor responses in both lower extremities and a pain sensation in her right and left lower extremity, but primarily her right. She's been running a normal sinus rhythm, S1 and S2 are heard, and there's no peripheral edema present. She's on room air, her respiratory pattern is regular and unlabored, and she has diminished breath sounds in her right and left lower lobes, with the other lobes otherwise having clear breath sounds. I would definitely recommend that you keep encouraging her to use her bedside incentive spirometer. She has bowel sounds present in all 4 quadrants with no pain or tenderness. Her last bowel movement was on 4/16. She's voiding with no difficulty, however, she is using a PureWick for her occasional urinary incontinence related to her pain. She has weakness in both lower extremities and is a fall risk because of her weakness and pain, and she's been using a nurse as an ambulatory aid. To encourage her ambulation while preventing fall risk, I've been assessing her physical readiness by analyzing her blood pressure, pain level, and use of glasses, etc. before we get up. I also educated her on fall prevention strategies by showing her where the call bell was and emphasizing the importance of calling before getting up so that someone can be in here to assist her. She's been doing that throughout the shift, so her teaching was successful. I've also been acting as her primary ambulatory aid, and with my help, she successfully ambulated 15 feet to the restroom without falling. Her skin is appropriately warm, dry, and intact, and she does have excessive general dryness. She has no open wounds or notable skin abnormalities. She has a peripheral IV in her left arm that's clean, dry, and intact, and has been flushing with no complications. Lastly, she's been expressing some concerns and anxiety about the progression of her pain and how it may impact her ability to work following discharge, as well as some discontent about having to eventually transition to an inpatient rehab facility. I assessed her current emotional state this morning as being distressed, and I identified spirituality as an area for supportive intervention. I offered to coordinate a visit with supportive services, and she was open to me coordinating a visit between her and the hospital chaplain. They met, and she felt it greatly reduced her anxiety, so I recommend definitely using this avenue if she feels overwhelmingly anxious again. I also showed her some new coping strategies for her anxiety, like journaling and deep breathing, and she ended up writing a journal entry by the end of the shift, so definitely keep encouraging this. Her daughter also comes in and visits every day, so she has that support system to rely on. That's about all I have for patient X. Do you have any questions for me?